We hope you're liking our new format. We start with a very brief roundup of the week's top stories from Physicians First Watch, read by First Watch's editor Amy Herman, and then we chat with James Douketis about how to manage anticoagulation in patients with atrial fibrillation who are scheduled for surgery.
Here are the top stories of the week from Physicians First Watch. First, a large UK study finds that teenage girls who use social media several times a day are more likely to report psychological distress later. And 3 factors seem largely responsible for that stress. These are cyberbullying, inadequate sleep, and insufficient physical activity. Next, an international study finds that 1 in 14 older adults who have non-cardiac surgery have a perioperative silent stroke, and these patients face greater risk for cognitive decline a year later. Elsewhere, the American Academy of Neurology and American Headache Society have issued new guidelines on preventing and treating migraine in children. The guidelines emphasize that most trials of preventive medications have failed to show any benefit over placebo, with 1 or 2 possible exceptions. Next up, a large meta-analysis finds that teens and young adults who use e-cigarettes are over 3 times as likely to also use marijuana as those who don't use e-cigarettes. And finally, in a randomized trial, 2 Ebola treatments were shown to be about 90% effective among patients in the Democratic Republic of the Congo. In contrast, 2 other treatments, including ZMapp, had only about a 70% survival rate. And that's it for this week. Now, on to Joe Ilia's latest clinical conversation.
Welcome to another clinical conversation. This time, we've got James Douketis, first author on a paper investigating a simplified approach to managing interruption of anticoagulants in patients with atrial fibrillation who are undergoing elective surgery or other procedures. The obvious problem is that some of these procedures can cause bleeding, and so you don't want patients to be too anticoagulated. Dr. Douketis and an international group tried a simple approach that doesn't involve so-called heparin bridging or testing for anticoagulation function. Dr. Douketis is a professor in the Department of Medicine at McMaster University in Hamilton, Ontario. Welcome to Clinical Conversations, Dr. Douketis.
It's my pleasure to be here.
Forgive me if this is a naive question, Dr. Douketis, but who manages these interruptions of anticoagulation? Is it the person doing the procedure, the anesthesiologist, primary care? Who's responsible for that?
The perioperative management of patients who are on an anticoagulant and require an elective surgery or procedure has been a bit of an orphan area in the sense that no dedicated group of physicians has taken ownership. Typically, we see internists, anesthesiologists, family physicians, sometimes the interventionist, or in less circumstances, the surgeon doing it. So the reason for providing healthcare professionals with a simple perioperative management approach was to allow, whichever group to safely and easily manage these patients.
Okay. So it's a whole range of people who could potentially be interested in your work here.
That is correct, yes.
You call the study the PAUSE study, which is an acronym for something, but actually it's well named because it's pausing or stopping anticoagulants for a bit. You recruited 3 cohorts of people on apixaban, dabigatran, and rivaroxaban. And they were in 23 clinical centers in the Northern Hemisphere, roughly speaking. Each cohort was designed to have 1,000 members, and everybody in the cohorts had atrial fibrillation. They were all at least 18 years old, and they were undergoing an elective and not an emergency procedure. Is that right?
That is correct, yes.
Okay. And the trial wasn't randomized. Can you talk a bit about that, why it wasn't randomized?
We did not do a randomized trial because there was really no viable comparator group. In other words, when the DOACs were first introduced about 10 years ago, there was no standard of practice in terms of how to manage the interruption and resumption of DOACs around the time of elective surgeries procedures. So our study was really a first attempt to provide what we thought was a baseline approach that was still intended to be safe and easy to implement. But a randomized trial requires a comparison group that's usually a standard of care, for which there was none in this group, or an alternative management approach. And at the end, you would end up with two experimental arms, which wasn't going to help clinicians in terms of what was the best approach. So we thought as a first step, a cohort design was an appropriate design given those considerations.
Okay. What you designed the study to do was based on the relative risk for bleeding in the procedure to stop DOACs. For instance, under a low-risk procedure, you would stop them a day before the procedure and resume them a day after the procedure. For the higher-risk procedures, you would stop them 2 days before and then reinstitute them 2 days later. Is that right?
Yes, that is correct. And it was intentional to do it that way to combine what we felt was an adequate interruption interval based on the pharmacokinetic properties of the DOACs, so to allow sufficient time for the DOACs to get out of the body. But at the same time, we wanted something that would be simple and easy for clinicians to remember and to implement in daily practice.
Can you give me an example of a low-risk and a high-risk procedure?
So a low-risk procedure that's done commonly would be an elective colonoscopy. So most of these patients are considered low risk. There's a small minority who may need polyp resections that are higher risk. But in a low-risk procedure like a colonoscopy, let's say they're having it on a Monday morning, then their last dose of their DOAC would be on the Saturday. They would not take any on the Sunday. They wouldn't take any on the Monday. And then they would resume their drug on the Tuesday morning. So 1 day off before and after. A high-risk procedure or surgery would be, let's say they're having a resection of their colon. And we know that those patients are at higher risk for bleeding, whether it's laparoscopic or open. And in that situation, if they're having the surgery on Monday morning, their last dose of the DOAC would be on the Friday. So 2 days off, and they would resume on the Wednesday. So 2 days off before, 2 days off after. Now, of course, there is a caveat to this approach, and that is that we cannot always predict what will happen during a surgery or procedure. In the colonoscopy situation, maybe the endoscopist finds a polyp that's very large. They have to remove it. In the surgery, maybe the bleeding is more than expected. So in both of those circumstances, the protocol allowed flexibility in terms of the timing of resumption so that it would be patient-specific. And, of course, the overall aim was to mitigate bleeding and to reflect the real-world clinical scenarios that happen in a perioperative setting.
I mentioned at the beginning of the interview that your approach did not involve testing for coagulation function. So why didn't you test for coagulation function? And if you did, what did you find?
In the PAUSE study, we drew a blood sample just before the surgery or procedure to measure the residual anticoagulant level, but we did not use that for any clinical decision-making, and the results were not available to the clinicians or the investigators until after the study was completed. The reason why we feel that a blood testing is not required is twofold. First is that with the DOACs, they have very predictable pharmacokinetic properties. So unlike with warfarin, for example, we know if we stop this drug, 2 days before, which really corresponds to about 60 hours from the last dose to the time of surgery, we know that there's going to be very little, if any, residual drug left. So doing a measurement is not going to be all that helpful. The second reason is even if we did want to do a measurement, measuring DOAC levels is not very easy. It involves tests that are not widely available, that do not have rapid turnaround times, like, let's say, an INR test for patients who are on warfarin. So it's not very practical in a clinical setting, is the second reason. But overall, the results of the residual blood levels showed that our protocol was indeed successful in the sense that very few patients had any residual anticoagulant effect. And the vast majority of them, the anticoagulant level was not detectable.
Okay. And so the basic outcomes were the incidence of major bleeding or arterial thromboembolic events within 30 days of the procedure.
Yes, that's correct. And arterial thromboembolism was defined. The other definition is stroke systemic embolism, so ischemic stroke, systemic embolism. And major bleeding was a standard, what's called ISTH definition, typically, drop in hemoglobin of about 2 grams or transfusion of 2 or more units of packed red cells.
Okay. And again, excuse my naivete because I'm not a clinician. Why weren't you also looking at venous thromboembolism?
We also looked at venous thromboembolic outcomes. We also looked at less severe bleeding, but these were secondary outcomes. The study was powered to look at what are considered the most clinically important outcomes, and that is stroke, systemic embolism, and major bleeding.
Okay. And speaking of power, the dabigatran cohort was only about 2/3 the target size. It was about 600 some odd members, and you were trying to recruit 1,000. And so the power of the observations then with dabigatran was less than with the other two DOACs. Is that fair?
It is and it isn't. It is fair in that we were hoping to recruit about 1,000 patients on dabigatran, but as I'm sure the audience knows, the use of dabigatran tailed off over the course of the study, and fewer people are using it in everyday practice. So the lower recruitment is a reflection of its diminished use over time. However, despite this, we did have sufficient number of patients to achieve our criteria for safety in terms of being able to exclude a 1.5% rate of stroke systemic embolism and being able to exclude a rate of major bleeding of 2%. So the actual event rates were such that despite the lower number of patients recruited, we nevertheless had adequate power to attain our pre-specified hypothesis.
So, but it wasn't at the 80% level.
I believe it. Yes, it was at the 80% level. That was the same power across the 3 cohorts. I guess you could say we got a bit lucky because the number of events in the dabigatran cohort were in proportion to the actual size less. And we did have that power to exclude rates of those serious adverse events.
Okay, so in your primary analysis cohort, the dabigatran, the maximum range of major bleedings did not cross 2%. It was 1.73%. But apixaban did not fulfill that criterion. You hit 2% with apixaban, and with rivaroxaban you hit 2.65%. So those are both admittedly low levels of major bleeds. And so my question is, do you think that more work is necessary before your interruption protocol would be widely used clinically?
The one way to interpret that is that we were fairly strict in what we considered criteria for safety, and when we say that we wanted to exclude a 2% rate of major bleeding events, we also need to consider that in a lot of the patients who had major surgery, for example, cancer resections, things like that, a lot of what we classified as major bleeding was in fact bleeding that was expected as a consequence of the extent of the surgery. So one might say that we were overly hard in terms of classifying these events as bleeds, and somebody might interpret these findings and saying, well, your rates of major bleeding outside of what would be expected are lower than what you're presenting. Now, in terms of whether we have sufficient confidence in the protocol that it is safe in terms of rates of major bleeding, and whether we need further studies, I think that's for the reader to interpret. I mean, we as the investigators are confident with this protocol that it is associated with low rates of major bleeding in both the low risk bleed group and the high risk bleed group. So we think that if we're going to do further studies, we probably want to go to randomized trials, and in fact, we are planning such studies.
Okay. What would you hope that clinicians do, Dr. Douketis, next week with knowing your results?
In terms of day-to-day clinician-patient interactions and management, we hope that clinicians will look at this and say, here's a relatively easy to implement, it appears, relatively safe approach to managing this common clinical problem. And, we hope that clinicians may consider it everyday practice. We hope that guideline developers will look at it and use it accordingly to advise in evidence-based practice guidelines. But we feel that it's something that, we'd like to think it's ready for prime time. Whether the everyday clinician thinks there needs to be more evidence, I think that's entirely up to them. But we feel very confident about the simplicity and the safety of the protocol.
All right. Well, good luck on the next phase of research on this, Dr. Douketis, and thank you very much for taking the time to talk with me today.
Thank you for having me on.
That was our 229th clinical conversation. The whole searchable collection is available free at podcasts.jwatch.org. Let us know how we can improve these chats. Email me, jelia@nejm.org. We come to you from NEJM Journal Watch. The executive producer is Kristen Kelly. I'm Joe Elia. Thank you for listening.